Hi. A very healthy, hearty good morning to everyone out there. We are live here right with you. So here I am at SL Raheja Hospital, Mahim, which is a Fortis associate. I, Dr. Sadia from Medical Oncology Department, a clinical associate to Dr. Bharat Bhosale, who is also my mentor, for which I'm eternally grateful. Thank you, sir. Thank you so much
Thank,
for I get to learn from you.
thank
So,
you, Sadia.
thank you, sir. Though Dr. Bharat Bhosale needs no introduction, but here I would like to add a brief about Sir himself. Dr. Bharat is a senior medical oncologist with an extensive training and super specialty from Tata Hospital and bone marrow and transplant in charge, and further experience and expertise from USA, Zurich, Singapore, and Austria. Working passionately in cancer care since more than 15 years now. His area of interest being precision oncology and the specialty being breast cancer, thoracic oncology, gastrointestinal cancer, lymphoma, hemat oncology, head and neck cancer. Hi, sir.
Hello, hello.
So now, when we proceed ahead, and if I may ask you, nowadays, when we see a humongous number of cancer cases emerging up, is it the actual hike in incidences or the better precise diagnostic tools?
So, first of all, Sadia and the viewers, thank you for having me here. And to answer your first question, yes, we are seeing increasing number of cancer cases, and there are various reasons to it. Most important reasons, one of the most important thing is the better accessibility to the healthcare. And especially after COVID, the healthcare facilities have been able to reach out to even the two-tier, three-tier cities. Maybe that is one of the reason because better healthcare access. But beyond that, what I see in my clinics, the age at which cancer is being diagnosed is also getting 10 years ahead of the Western countries. More and more younger patients are developing cancer. Though there are no other reasons like genetic background, but yes, I do see the number of cancer cases are actually going up, and mostly because of the lifestyle changes. Obviously, the environmental changes, the bad habits like smoking and alcohol, are especially in the metros. The cancer like breast cancer is on numbers are increasing. At the same time, the better hygiene and the infection-related diseases are going down because of the percolation of the vaccination programs. So these are there are various reasons, and cancer is a multifactorial disease. So as you asked me about the numbers, the concern is the numbers are definitely increasing, and in coming years we are going to face this is as a non-communicable disease and one of the important chronic disease like the heart diseases, neurological disorders, the chronic disease. So we have to live with it, and it's better to be prepared, and that is what we are
Yes.
trying to discuss today through Precision Oncology Talk.
Sir, if you can throw some light on what exactly is precision oncology? Is this approach helps to match the right patient to the right medicine at the right time?
So, Sadia, as you know, that we have been dealing with this disease not 10 years, 20 years, 100 odd years, or more than that. The cancer was there since ages. And as the treatment of cancer started, the most important treatment as cancer, there are no different organ can develop cancer as well as the blood, but largely we talk about no solid tumors. So we'll keep our talk related to solid tumors. We'll obviously discuss some of the liquid tumors like blood cancer. So surgery, as you know, a mainstay of treatment has been there. Then slowly, the radiation evolved, and then later on, chemotherapy became a part of cancer treatment. Then we realized, even after doing treatment of the cancer in early stages, after some time, that no, all these treatment fail, and the patients come back with cancer. Obviously, all these treatments are associated with side effects also. So there is something called as effectiveness, and the other side there is something called as side effect or no immediate or long-term side effects. So age-old chemotherapy has been there, and success. I must say that because of the chemotherapy and the proper scheduling of the chemotherapy, the malignancies like pediatric cancers, pediatric leukemias, the cure rate has reached beyond 90%. Some of the pediatric cancers, some of the blood cancers are treated with chemotherapy, and the cure rate is beyond 95%. So chemotherapy was there, chemotherapy is there, chemotherapy is going to be there. It's not going to be completely no chemotherapy. Our approach precisely is looking at how we can reduce the side effects of the chemotherapy. So that is also preciseness of looking at the side effect. But nowadays we understand there are stages of cancer. Broadly, I'm talking about all the cancers, stages of cancer. Then there are advanced cancers where surgery and radiation do not play any role in the treatment of cancer. Like when we label it as a palliative situation, when the patient goes into stage 4, when there is no surgery, when there is no radiation, we label it as palliative. And when the palliative terms comes, sometimes people feel that it's like 2 months or 6 months. But to tell you, in cancers which are stage 4, now patients are living beyond 10 years. Some of these patients are being labeled as cured. And that is possible maybe because of something called as a precision oncology. Now, if you go to the other spectrum of the disease, that stage 1, which like we call it's precision oncology evolved beyond the concept of one size fits all. One size fits all, that means chemotherapy is not everything for all the stages or all types of cancer. So let's take an example of a breast cancer. And as
Yes.
you know, in breast cancer, majority of the patients are hormone positive, right? So in stage 1 breast cancer, those females who are ERPR positive, where the proliferation rate is very low. Actually, there is a clinical trial in which they looked at if you do particular genomic signature called as the oncotype DS, and there are other signatures too. You can actually tell the patient precisely that you do not require chemotherapy, and with 100% confidence. Why this is possible? Because there is a background where in the laboratories, in the research laboratory, a decade long research has happened. They could break the code. We call it as a genomic signature. In a breast cancer, there are a couple of genes which decide how the genes are manifested in the tumor. So in the laboratory, our scientific or researchers could break that code, and they come up with particular score. And if the score is below particular value, you can actually avoid chemotherapy. And before that, every single patient after surgery used to take chemotherapy. Now, this is possible not because of the clinician sitting. It is possible because someone back in the research lab has worked years, and decades to break that code. So, this beautiful translation from the bench to bed, we always talk no bedside discussions, that research happens in the lab and then we deliver it bedside to the patients. So this entire journey is the backbone of precision oncology. And because of this, we can avoid delivering of chemotherapy, which can be toxic to certain extent for early stage breast cancer. So I talked about stage 4 cancers where I am going to elaborate it further. But in early stages of cancer, because of the precisionness, we are able to deliver right treatment to right patient in right time. That means it's not only the delivery, but sometimes avoiding a toxic treatment. So, precisely hitting the target is something which we can say, and every oncologist or every clinician should learn. Next couple of minutes, we'll talk about different cancers.
Yeah.
This I talked about the breast cancer, which are ERPR positive. Now, coming to the other type of breast cancer. So, I always tell my patients when somebody walks in, suppose I am seeing 10 patients of breast cancer in a day, means does not mean I should plan the same treatment for all those 10 ladies. So 10 different patients can get 10 different types of treatment. And that is preciseness. Right treatment to right patient in right
The
time.
right. So, can you exemplify the precision approach in oncology in a way that is easily understood to the viewer? Giving an example which can be easily understood to the viewers.
So briefly, I'll divide into precision oncology does not mean you have a patient and give the treatment. Start from the prevention. So There are breast cancers, ovarian cancers, and in the laboratory, this was a works, as I said, of decades. The scientists and the molecular pathologist, our radiologist have worked extensively to break the genomic code. Now, people will say only no genetic studies and molecular studies and getting molecular reports is only precision oncology. It's not that. Like if you have a different mutations which are picked up as germline or somatic mutation, they are translated into therapeutic approach. But prevention or preventing cancer occurrence in a patient with a family history and a known germline mutation, that is possible because you are now able to decode the genetic mutations. So there are patients with the family history and particular germline mutations. You can actually start preemptive practice of preventing the disease, early detection. So prevention and early detection is also possible. Prophylactic surgeries are happening. That's a different topic. But what I'm trying to tell you, precision is not only the treatment, but sometimes by prophylactic approach you can actually prevent the occurrence of disease. So like a BRCA mutation, a family can get counsel and get that test done. That is also precise approach where no prophylactic surgeries can prevent the occurrence of disease, but that may not be always necessary. Proper screening can detect the disease in early stages, where, as I mentioned, early stages we can avoid the toxic treatment. Then comes the diagnostics. In diagnostics, so it's basically a spectrum, right from the prevention, diagnosis, and treatment. Everything is it's a precise precision oncology. In diagnostics, sometimes we come across tumors, say example as a sarcoma, and we can't, based on the traditional way of histopathology and immunohistochemistry, it sometimes becomes difficult to know label that which particular type, because there are 20 plus odd type of sarcomas, and every sarcoma can be treated differently. As I mentioned, sarcoma is a soft tissue and bone tissue cancer. So they are different from regular carcinomas. That's why they are called as a sarcomas. They comes from the supportive tissue. Now, in that, if you have a diagnostic dilemma, sometimes the precision oncology comes for help. We do genomic sequencing, and that can be done through various ISC methodologies, PCRs, FISH, which is a fluorescent in situ hybridization test, and then the newer techniques is NGS. Largely nowadays, we run various panels of genomic sequencing, and which helps to precisely diagnose. So then, whether it's a diagnosis A, the patient goes for different treatment. If the diagnosis is B, the patient goes for different treatment. That is why, for a clinician, the molecular pathologist, the radiologist, the intervention radiologist, they do play a significant role. Their contribution in the treatment planning is very, very important. If I diagnose correctly, I treat the patient correctly, my outcome is best. So all these players are very important. All these team players are very important. So precision oncology is teamwork. It's not only like Dr. Bhosale is coming and advising tests. There are people who are not in front, who are not seen, but they play a major role in treatment, delivery, diagnosis. So it's prevention, it's diagnosis and treatment. This is all about precision oncology.
Thank you, sir. That was quite informative. My question now is, what are the areas included in precision oncology?
So by this time, you must have realized that precision oncology starts from the laboratory, and nowadays
Yeah.
we are talking about precision oncology in India. It's there since beginning. What I feel, precision oncology was there. If you remember, in 90s we used to do bone marrow transplant for chronic myeloid leukemia. And now what we are doing, we are treating chronic myeloid leukemia with simple tablets. There are various tablets now. Originally, when we started, there was imatinib only. Now there are dasatinib, and there are newer treatments. So for a disease which is a blood cancer, which used to be treated once upon a time with interferons and bone marrow transplant and chemotherapy, in 90s and 2000, that decade, a lot of research happened, and they could break the code that this cancer is driven by a particular mutation called as a BCR-ABL. And then subsequently, discovery of a drug which can be taken orally, imatinib, happened. And majority of the patient now are to be majority all the patients are now being treated in chronic phase with oral tablets. So we could translate a deadly disease into a chronic disease, wherein patients are now taking one tablet, like patients of hypertension and diabetes, and are labeled as completely cured. Some of them do not respond. We do again genomic testing to detect whether there are mutations causing resistance, and subsequently there are more and more drugs are coming up which can actually face this the obstacle and overcome this obstacle. So this is called as precision. This is called as precision. And it's not only, I feel, no genomic studies. Previously we used to treat all lung cancer with chemotherapy. Then the biopsy came into picture. Then the immunohistochemistry came into picture. We divided them into small cell, non-small cell, adenocarcinoma, squamous cell carcinoma. And based on that precision diagnostic immunohistochemistries, we started treating different cancer with different chemotherapies. Beyond that, then there was a discovery of EGFR mutation. You remember when I was a fellow in Tata Memorial, we started getting these EGFR. That was the initial years when the EGFR positive lung cancer. And now you see these patients are being treated with tablets. So that time the
Yes.
cost of treatment was also for a month was 1.5 lakh and above that. And to get those diagnostic tools by simple, initially they started doing IHCs, but no, that was not the standard. Then they started doing hotspot, PCR based tests. Then subsequently, no NGS came into picture. So that time we used to be happy to get a patient with EGFR mutation. So this is precision oncology. You select a patient with a particular mutation, which can be a point mutation, which can be translocation, which can be a fusion. And those days, you treat those patients with tablets, no chemotherapy is required, and patient becomes better in 7 days. Even the patient who used to come on a wheelchair or stretcher used to walk to the OPD within 7 days of starting treatment. So, a more effective, less toxic treatment is chosen for a patient who used to be treated with chemotherapy, which might not have been effective for all patients. So the number of patients responding with this precise treatment is goes up, the toxicity goes down. Then subsequently, lung cancer, we started developing more and more panels to pick up more mutations like ALK, ROS, and nowadays, more than 10 mutations are actionable. That means you can pick up a mutation. See, these tests to detect these mutations are called as a genomic, and that's the backbone of precision oncology. You get a tissue or a blood, and you run those genomic markers in the laboratory, and you get various mutations. Normally, what happens, you can get n number of mutations because in the body the mutation keeps on happening. But whether that mutation is clinically relevant, whether that particular mutation is driving force for the cancer occurrence and metastasis, that is very important. Then if I get any mutation, whether there is a treatment available for that. Then if that treatment is available, whether it is at research level or it is already into practice, then whether that treatment is actually available in your country or your country approves that. So there are various levels. Then comes a point, if it is available to you, what's the cost, and whether your patient is able to access that, because there is something called as a financial toxicity. And if it is not, then how we can get access to that treatment, not in your practice but through a clinical research. So that needs to be that information needs to be available to each and every clinician, and especially the patient should also know what is this precision. Then there is point. Otherwise, what happens? It becomes a costly affair. You can do. There are tests available of 4 lakh, 3 lakh, 1 lakh, 30,000. Then the clinician must know. See, there is a famous dialogue from the movie called Spider-Man. A big knowledge or big responsibility comes on your shoulder with a great knowledge. No, I see that sentence is very important. When a clinician gets a knowledge, there is a responsibility to deliver that knowledge for the benefit of the patient. So when I put up a test on my paper for a patient, I need to know what are those implications. If I'm going to get a mutation, whether I'm going to get, what is the probability of that mutation is to be pathogenic. Some mutation I get, but whether that is pathogenic, whether there is going to be a treatment available for that patient, and what is going to be the cost of that treatment, or there is a research available where my patient can get benefit out of doing all these exercises. And fortunately, Sadia, in our country, various laboratories are coming up with cost-effective packages. Our cost of diagnostics in molecular oncology are going significantly down. The cost is 10 times less as compared to the Western countries. Unfortunately, the insurance coverage is not great in our country. Even if it is there, sometimes the insurance companies are not accepting these newer modalities. So there has to be awareness at the insurance company level also, that this is a newer branch. Every patient need not be treated with chemotherapy. Sometimes now it's more than 20 years that trastuzumab, which is targeting the HER2 in breast cancer, is available, but still no insurance companies are creating hindrance that this is a targeted therapy. So in precision oncology, largely we cover targeted therapies, immunotherapies, but choosing right chemotherapy for right patient is also precision, what I say.
Yes, very well said.
We,
So when you talk about
the viewers, I think, largely know now what is precision oncology. It's
yeah.
basically a knowledge obtained from the tumor biology, which is used for better effective treatment and lesser side effects. And that leads to immunotherapy, targeted therapy, which are oral treatments, IV treatments.
So when you talk about the cost effective drugs, so here when we come to know the promising newer treatment approach now, here the question that comes to my mind is the major challenges, uh, the way we were
Yeah.
talking
So,
about the cost of the
so
drugs.
now I see we are towards the end of our topic. So before starting cost-effective approach, because of the precision oncology, I will tell you in colon cancer and stomach cancer. You are aware of one of our patient who is a stomach cancer patient. I'll just briefly tell you about to our viewers. This patient, as per the standard treatment, was diagnosed with stage 3 stomach cancer. The treatment is chemotherapy 4 cycles, then surgery, and then chemotherapy. And one of the reputed hospitals started his chemotherapy, and on the scan they felt that there is a stable disease. Patient was actually taken for the surgery, and on the table when they opened up, sometimes there can be discrepancies in the PET scan and the surgery. The surgeon decided this is not a operable cancer, maybe labeled it as a palliative. So from the curative setting he was labeled as palliative, and then he was sent back to the medical oncology department for further planning. If you remember, that patient has got a biomarker. Biomarker is anything which can be detected by IHC or genomic testing like NGS, which is present in
MSS.
the tumor genetic mutation, or the mutation can express and forms the protein. So there is something called as a genomics, there is something called as a transcriptomics, there is something called as a proteomics. All this information is important to understand the biology of the patient. Now that patient was positive for MSI, which is called as a microsatellite instability. Instability because of the ongoing mutations, the genome become instable, and it has something to do with the DNA damage repairs. Okay, there are genes which are involved in the repairs. So this patient has MSI high, and then because the chemotherapy has already been delivered, there was no effect of the
Four
chemotherapy,
cycles.
it was abandoned. This patient was offered immunotherapy. Now, the cost of
Yes.
immunotherapy, if you look, is the cost is 4 lakh rupees per cycle, and the patient has to take in a palliative setting. You don't know when to stop, at least 1 or 2 years, if the patient responds. Now, the question comes of the cost. Here, we decided in a tumor board. Now, precision oncology comprises all these pathologies, molecular pathologies, radiologists, and medical oncologists, and surgical oncologists, and radiation oncologists. The decision is taken together. We decided we will give the low dose of immunotherapy, which can be at least accessible to the patient. It's because of the having access to a treatment. And I told you, there are trials ongoing, and one of my friend has done. Dr. Patil has done a trial, and I probably used low dose immunotherapy long back, 10 years back, and probably one of such patient in the country, first patient. This patient, if you remember, 2.5 years back, received the first dose of low dose immunotherapy. After the first dose, sometime the patient either respond, or there can be a slight increase in the tumor size, or sometime because of the immunotherapy there can be hyper progression. The patient landed up after 15 days with a gross pleural effusion. Sometimes what happens, people label it as a hyper progression, patient progression, and stop the treatment. But I had a curious mind, and I did the pleural tapping and discussed with my pulmonologist friend and asked him to rule out tuberculosis. So patient walks in after 1.5 months in OPD, absolutely normal. Because that pleural effusion was tuberculosis, he was treated with AKT, it was not cancer progression, and we did the scan, the disease was under control. Then after 3 months from the first dose, which is also low dose. We
Mhm.
started the immunotherapy, and you know that patient still follows after 2.5 years, and the
We've
recent
done,
three
yeah.
PET scans were clear, absolutely clear.
And we've
So
done 33 cycles, sir.
yeah,
Mhm.
so this is possible because we could precisely get right treatment to right patient in right time, but at the same time, the clinical evaluation looking at the patient is very important. Why I told you this story? Subsequently, we did is long back.
Yeah.
Subsequently, the paper came in 20 patients in rectal cancer, where the standard of care is radiation, because rectal cancer the tumors are low lying, and if they are low lying, the patient has to live entire life even in early stages with stoma is like externally you create the no cut the colon, get it outside, and the stool passes from the stoma. Because the tumor is sitting at the sphincter, the patient loses the voluntary control over control of the passing the stools. So this is called as a this comes with the morbidity. The surgery comes with the morbidity. The standard treatment is radiation, surgery, and then chemotherapy. So those 20 patients of rectal cancer, those who are positive for this MSI are treated without radiation, without surgery, and all those patients showed that the disease has gone completely on the subsequent MRI. Means if for subsequent years there is no recurrence, in future we might be selecting these patients of MSI for immunotherapy only. This is called as the right treatment for right patient in right time, which not only effective but reduces the morbidity of other treatment. Then subsequently the trial came of colon cancer, in which the standard of care is surgery and then giving chemotherapy. But now in this trial, what they did, because there was a trial of giving chemotherapy before surgery in colon cancer, they tried immunotherapy in this particular subset of patients who are MSI high, and they found that 110 odd patients, if you pick up this MSI high patient in colon cancer, 70% of this patient, no, the tumor disappears completely when the surgery was done. Means the immunotherapy is effectively eliminate even no single cell, doesn't keep a single cell in the body, and probably we are looking at a future to do genomic coding of all the cancer, see what mutation is there. See, today we are looking at the genome, we are getting mutations, but not all mutations are targetable. But today, a mutation which is not targetable can have a drug after few years, can have a drug in going on the research trial. So this is called as no precision. This is called as a precision. You study the tumor biology through its clinical behavior, through its radiology, which is called as radiomics. Then comes your, after your clinical assessment, your radiological imaging, you comes a normal histopathology, ISCs. You study that tumor into depth. Don't miss out any point. Subsequently, process that tumor for genomic alterations for majority of the cancers, like the best example or the the poster boy of precision oncology is maybe lung cancer, in which we'll get lot many mutations which are actually actionable and targetable. So you look for that, which through which you understand the biological behavior of the tumor properly, so that you can choose the right treatment for that right tumor in right time is very very important, and that is the beauty of precision oncology.
So, can we talk about the side effects of precision therapy, if
So
any,
there are no
or
side effects as such, because as I told, sometime people can do genomic studies for all patients. As I said, the responsibility on us, because it is very costly affair. You need to be very choosy. You need to know which patient is to be taken for a particular investigation, and if the investigation comes positive, because not all the mutations translate into protein which can express. You need to study that in detail, whether if I get a mutation, it may not be always actionable. So you have to discuss with the molecular pathology lab in detail before delivering those, because these treatments are very costly. So largely these are no financial toxicities, but yes, these immunotherapies are associated with immune related toxicities. Targetable treatments are associated with their skin toxicities, cardiac toxicities. So the internal medicine people, those are community physicians, should also, they must get a knowledge about these newer treatments and should pick up those toxicity at earliest. So largely it is responsibility of a treating oncologist to treat with the right test, choose the right test, and if the result comes positive, there has to be counseling pre-test and post-test what we are going to do it. The patient also needs to understand what is the patient's expectations. No, now that does not mean every patient should come and no start talking about precision oncology. Largely, we do it in breast cancer, lung cancer. No, there are other cancers where no melanoma. We
Mhm.
look for some mutations and get a targeted treatments. So we are evolving. Now, neurological tumors also know we are processing for precision markers to decide the right dose of radiation and drugs, which patient is going to respond to the drugs. So it is happening almost in all tumors, but we have to be selective.
Yes. So now, when we come to know the major challenges and when it is indicated and the limitations, the side effects. So, in all, if we sum up and we would want to know why would we choose precision therapy when cancer is diagnosed, a certain kind of cancer is diagnosed? Why and when?
So the
And
first
how
goal
to?
is no, yeah, the first goal. Yeah, you were saying
Yes.
something.
Yes, sir.
So, lastly, before concluding, I must say that cancer treatment has no evolved over a period of no 100 odd years, and everybody is chasing cure. Like so far we are not at there, but it is good to see that no large number of patients are getting no even in stage 4 living more beyond 10 years, and this is possible because of choosing right treatment for right patient in right time. I think the coming years are going to be exciting because there are cellular therapies like CAR T therapies are coming, which are being utilized in patients who have received 10 lines of treatment. Means the patient had received 10 different lines of treatment failed, and you have used cellular therapies, and the patient is labeled as cured. There are gene therapies are coming up. No, adaptive cell therapies are coming up. So coming time is all about no ongoing research, as I mentioned, coming from bench to bedside, and we are looking at no getting cure for all the cancers. Yes, cure has come to some cancers, but now in future we are near achieving cure for almost most of the patients, and that I think is not possible without talking about precision oncology. Thank you.
Okay, so it looks like we have gained a lot of information about this newer treatment, which is none other than precision based treatment. Thank you so much, sir, for giving your valuable time to us and our viewers and
Thank you.
enlightening us and being there always. And I want to tell my viewers if any queries or any further consultation, we are right here at SL Raheja. Sir is available for the consultation. Thank you so much.
Thank you. Thank you. Thank you.